Your knee is grade 4, it's bone on bone, nothing else will work. You need a knee replacement. But I want you to understand something very important. Grade 4 is a radiological grade, it is not a treatment decision. And bone on bone does not automatically mean that your knee is beyond preservation. Now, I need to be equally clear about the other side. I am not saying that every grade 4 knee can be saved. I am not saying knee replacement is wrong. And I'm certainly not saying that biological treatment can regrow a completely normal knee. What I'm saying is much more precise. An X ray alone should not decide the fate of your knee. When we grade knee arthritis on an X ray, we often use the Kellgren Lawrence grading system. Grade 4 is the most advanced radiological category. You may see severe joint space narrowing, large osteophytes, subchondral sclerosis, and changes in the shape of the bone. And when the joint space becomes extremely narrow, people commonly use the phrase bone on bone. That sounds final, but remember what the X ray is showing you. It is showing structure. It is not directly measuring your pain. It is not measuring your inflammatory environment. It is not telling us everything happening inside the subchondral bone. And it certainly doesn't tell us whether your knee is still biologically and mechanically salvageable. Two people can have very similar x rays and very different symptoms. One may barely walk, the other may still be working, exercising, and climbing stairs. So the x ray matters.
Both of these patients have grade 4 knee osteoarthritis, yet their daily mobility and pain levels are vastly different. Treat the patient, not the X ray.
But the X ray is one part of the decision. This is where the old wear and tear model becomes too simplistic. Osteoarthritis is not simply cartilage wearing away like the tread on a tire. The knee is a living organ. Cartilage, subchondral bone, synovium, meniscus, ligaments, muscles, inflammatory cells, blood vessels, nerves.
First, we examine the smooth articular cartilage. Directly beneath lies the porous subchondral bone layer. Next, the vascular synovial, we reveal the deep neurovascular bundle.
All of these interact. And interestingly, cartilage itself does not contain pain fibers. So when somebody with grade 4 arthritis has severe pain, we need to ask, where is that pain actually coming from? The synovium, the bone underneath the cartilage, a bone marrow lesion, mechanical overload, instability, inflammation, or several of these together. That question changes the conversation completely because instead of asking only how much cartilage has disappeared, we start asking what parts of this knee are still treatable. There is an important long-term study by Hernigue and colleagues. Patients with osteoarthritis affecting both knees received bone marrow concentrate into the subchondral bone of one knee, while the other knee underwent knee replacement. These patients were followed for many years, and the biological treatment knee did not inevitably progress immediately to replacement. Some knees remain preserved for remarkably long periods. Think about what that means. It does not prove that bone marrow concentrate cures grade 4 arthritis. It does not mean it works for everyone, but it challenges the idea that once advanced arthritis appears on an X ray, the biological conversation is automatically over. It isn't. Other clinical studies have investigated biological approaches in advanced osteoarthritis. Randomized clinical data have reported improvements after cell-based treatments in selected patients. Studies combining stromal vascular fraction with platelet-rich plasma have also reported symptomatic and functional improvement in advanced knee osteoarthritis. Again, I want to be very careful with the interpretation. These studies do not prove that we can rebuild a normal grade 4 knee. The evidence is still evolving. Protocols vary, patient selection varies, and structural regeneration is much harder to demonstrate than improvement in pain and function. But the evidence does tell us something important. Advanced radiological arthritis does not automatically equal biological hopelessness. So, can a grade 4 knee be preserved? Sometimes. And that word is extremely important. Sometimes. The real question is not, do you have grade 4 arthritis? The real question is, what kind of grade 4 arthritis do you have? The grade 4 knee, I would not try to preserve. Suppose the knee has major fixed deformity, severe loss of movement, a significant flexion contracture, major instability, severe mechanical collapse, or advanced disease in compartments where the remaining joint mechanics are extremely poor. In that situation, biological treatment may be asking biology to solve a mechanical problem that biology cannot solve. And that is where knee replacement may genuinely be the better option. I do not believe in avoiding knee replacement at any cost. I believe in avoiding unnecessary knee replacement while recognizing when replacement is actually the correct operation. But there is another grade 4 patient. Now imagine someone else. The x ray says grade 4, but the knee still moves reasonably well. There is no major fixed deformity. The alignment is acceptable or manageable. The knee remains mechanically functional. And MRI and clinical assessment suggest that important biological targets still exist. That is a completely different patient. That patient deserves a more sophisticated conversation than bone on bone. Nothing can be done. This is why I don't treat the x ray. Before deciding whether a grade 4 knee is suitable for preservation, I want to understand the whole knee: alignment, range of movement, stability, patellofemoral disease, meniscus, synovitis, subchondral bone, bone marrow lesions, metabolic health, and the patient's functional expectations. Because a grade 4 knee in one patient may be a reasonable preservation candidate, while a grade 4 knee in another patient may be a poor candidate. Same grade, completely different decisions. This is also why my approach is not simply inject something into the knee and hope cartilage grows. That is not how I think about advanced osteoarthritis. If the joint remains biologically destructive, if inflammatory and proteolytic activity remains high, trying to stimulate repair without addressing that environment may make little sense. That is the reasoning behind A coverage. First, we try to address the hostile biological environment. Then, in appropriately selected patients, Prasad approaches the knee as a multi-tissue problem, including the intra-articular environment and the subchondral bone.
Step 1. Akavach uses capture and neutralize destructive enzymes. Step 2. Prasad delivers targeted therapy directly to the subchondral bone scaffold.
But neither A Kavach nor Prasad changes the fundamental rule. Patient selection comes first. If you have been told that your knee is grade 4, don't panic because of the number. But don't ignore it either. Grade 4 is serious disease. Instead, ask better questions. How much movement do I still have? Is my knee deformity fixed? Is the knee stable? Where is my pain coming from? What does the subchondral bone look like? Is there active synovitis? What does the MRI show? And most importantly, is this particular knee still a realistic candidate for preservation? Sometimes the answer will be no. And when replacement is genuinely the best option, that should be said clearly. But sometimes the answer may be yes. So if somebody tells you grade 4 means nothing else can be done, remember this. Grade 4 describes what the X-ray looks like. It does not by itself tell us everything about what the knee can still do, what is causing the pain, or what biological and mechanical target remain. And it should not by itself decide your treatment. I am not saying knee replacement is wrong. I am saying an X-ray alone should not make that decision. Before replacing a knee, find out whether there is still a knee worth preserving. I am Dr. A.K. Venkatachalam from the Madras Joint Rejuvenation Center.